We have Dr. James Leonard. He's an orthopedic surgeon who has been with Midwest Orthopedic Consultants for more than 10 years.
Yeah, it's
So
11
more than
years
that by now.
September. 11 years September 1st.
Okay,
Yeah.
all right. He was named at Northwestern University, University of Illinois, and Chicago and Vanderbilt University, where he was the team physician for Vanderbilt athletics and the Nashville Predators and the Nashville Sounds. He specializes in shoulder, elbow, and sports medicine. In addition to his clinical practice, Dr. Leonard has interest in athletic coverage, education, and research. He is the team physician for Carl Sandburg High School, Marist High School, and USA Hockey. When do you ever have time to?
I actually just got back from Buffalo last night.
Oh my
so
goodness.
We had tryouts for the USA Hockey team. So I got back last night. So
Awesome.
yeah, it was good.
Yeah, hopefully you're not going there in the winter again.
We're going
They were shut in
to
last year.
we're going to Turkey in March for
Oh,
2.5
wow.
weeks. That's where we're going. So
Awesome.
I didn't know that they played hockey in Turkey, but apparently they do.
Cool. Were you a hockey player?
I was not.
Okay.
I was not.
Is
They
it
didn't have
really-
hockey when I grew up. You know, it was either basketball, baseball, or football. Those were the only three sports
Right.
I played.
Right, yeah. He is clinical instructor at the University of Illinois, Chicago, is a master instructor in orthopedic education. Excuse me, he serves on the editorial board for multiple orthopedic journals and is heading a national research group on partial thickness rotator cuff tears. He is member of the Bone and Joint Institute at Advocate Crest Medical Center, and his office is in Oak Lawn and Orland Park. So welcome and thank you.
Thank you very much. Thank you, everybody. All right. So I was here about 2 months ago. Is that right? It was only a month ago? Oh my God.
Time
Time's
flies.
going,
You've
I know.
been busy.
Yeah.
Because you've been here, there, and everywhere.
And you know, I did a talk on kind of the shoulder, which is kind of one of my passions. And you know, what I tell people is that, you know, sports medicine is all about being on the yearly cycle. Like you kind of get an idea based on what time of year it is, what I should be doing. So like right now, my brain is in like football mode. So, you know, I have games to cover Friday and Saturday. I start seeing a lot more football athletes. My wife gets more mad at me because I'm at a game every Friday and Saturday night. I don't see her that often. So it's about that feel. You know, like I said, I typically have, thank you. Typically do some hockey stuff in the summer. So I just got back from a 5-day course in Buffalo. And so I was thinking about a topic, and the whole concept of kind of the weekend warrior came up, something that I thought, where, you know, a lot of people are going back to activities, people are being much more active. And as people have become much more active, there's been a lot more injuries. You know, it's always a boom in orthopedics whenever a new fad comes out, you know, CrossFit, I see more patients. You know, anytime there's something new, you know, everyone goes all in on those things. And then I get a ton of patients going about those types of activities. And so, you know, that's kind of the topic of what we're going to talk about today with this. So thank you to Advocate for, you know, setting this up and organizing this and getting the word out. I'm appreciative for all the efforts that have been put in. And again, for the second straight time, trying to figure out my file, which I can never figure out how to send to you guys. Eventually I'll figure it out. There's my stuff. I work for Midwest Orthopedic Consultants. I've been with the Institute since I finished my fellowship in 2012. I specialize in shoulder, elbow, but I also still do sports medicine. That's basically what my specialization is in. I do shoulder replacements. I don't do knee replacements. I try to keep those guys out of business as long as I can. There we go. Again, my passion though is in my coverage things. I love my coverage. Even when I was a resident here, I was covering St. Rita, Morgan Park, and a lot of the Southside schools, kind of where I grew up. When I went away to Nashville for a couple of years, I worked with the Predators, which is the NHL team. I worked with the AAA baseball team, did a lot of work with Vanderbilt, got to go see a lot of fun places. And then had kids and had to come back home and take care of the kids. And so I still do a lot of this stuff now. This picture in the middle, this is me with the Italian EMTs when I was covering the World Championships in Milan. And so those are my helpers there. On the left is a picture at Sandburg, and then on the right is the athletic trainer at Marist. And I'm still at a game every Friday and Saturday night until Thanksgiving, starting this week. So, but I love doing it. And like I said, kind of my brain is, this is that time of year for this. And then I do a bunch of other educational stuff. I'm always trying to stay busy. I can never sit still or do the same thing. So I always have to be doing different things at different people. This is the second lecture I've given today. I gave one at 6 a.m. to the residents. And so the day is almost over. So we're going to talk about the weekend warrior. And so the first thing that people ask is kind of, so what is the weekend warrior? And so basically it's most of us, right? It's most of us that basically part-time kind of physical activities, we're people that we work, we're at home, we're sitting down for 40 to 60 hours at a time. And when we're not, we try to be as active as we can, doing whatever activities that might be. Pickleball is really big right now. So I'm seeing a lot of pickleball athletes that are kind of going in there. But I still see, again, this is also the time where I'm starting to see a lot of runners. They're finishing up their training for the marathon. So they're starting to have some of these little injuries that are going on. And so, again, I kind of have an idea of where we are in the calendar based on what kind of injuries that I'm going to see. I'm going to start to see a lot more ACLs, a lot more ankle injuries as football starts and soccer starts, see a lot more shoulders as volleyball season starts. So a lot of these things are cyclical. It's interesting. The World Health Organization recommends that we all do about 2.5 hours of aerobic activity per week. Okay. But in terms of how we normally manage that, instead of spacing this out nicely and doing maybe 20 or 30 minutes at a time, we tend to do it basically all in 1 or 2 days. So we just go crazy saying, well, I'm busy Monday through Friday, so I'm going to do all of my activities on Saturday or all of my activities on Saturday and Sunday. The other thing is that, there's been a rise in recreational sport leagues. Anywhere you go, you can find a basketball league, a hockey league, a pickleball league, and typically they tend to be over the weekends or at night where we go crazy and do a lot of activities. And all of these things have led to just basically us, instead of doing 20 or 30 minutes a day, we're doing 2.5 hours in a day or two. This is actually showing kind of what activity does. And we know that activity is really good for us. And so what we look at here is, if you look at these pictures, on the red is someone who's inactive. So it shows the risks of people in terms of mortality, the risk of cardiovascular disease, as well as the risk of cancer. And as you can see, is that any little bit of activity actually causes that risk to go down. So if you look here, the orange is being insufficiently active, meaning you're doing less than 2.5 hours. You're maybe doing an hour a week, 30 minutes a week. The green is being regularly active. So again, all-cause mortality goes down about 35%. Risk of cardiovascular disease goes down 41%. Risk of cancer goes down 21%. And then in the very right is the weekend warrior. So even if you are a weekend warrior, there's a tremendous amount of health benefits in terms of being a weekend warrior. That's much better than just being, inefficiently active, but not as good as doing it regularly. And so it's still good. So again, the point here is not to say that weekend warriors are bad. There's a lot of great things that go, but there's also a risk when we tend to concentrate things in a short period of time. And so, why do weekend warriors get injured? Unfortunately, we're not as old as we were. You think about, okay, you try to go back to your high school years and say, oh, I can play sports like I was in my 20s or 30s or 40s. It's fine. I'm the same as I was. I'm as young, as spry as I was. But unfortunately, we're not. And as we get older, certain things start to kind of fall apart. Also, not only do we get older, but we tend to get heavier, and so most people are going to be have a little bit more weight. And with increased weight, things aren't moving as efficiently as they can. There's increased stresses on the joints, and that leads to increased risk for injury. Again, being deconditioned. If you're only working out once or twice a week and you're not working out regularly, you're not going to be as in much shape as you were 10, 15, 20 years ago. And because of that, your muscles are stiffer, they're weaker, and that leads to an increased risk of being injured. And then again, a history of competitive play. Once you start getting back in activities, a certain switch goes on, and you just go on like you're never going to get injured again. And so all these things can kind of lead to injuries. And so what does that mean? So common injuries we see are muscle strains. And these are the run-of-the-mill muscle pulls. You pull a muscle, you get some swelling, you get some pain. A week or 2 weeks that goes away. A ligament sprain. So the ligaments are the structures that keep the joints together. So if anyone has ever sprained an ankle, that's a ligament, and you can do that to any ligament in your body. Any joint in your body can be sprained. And again, swelling, pain, stiffness. You can get inflammation or tendonitis. That tends to be more the overuse. You think about in the fall as we start to rake leaves, that soreness we get after we've been raking the leaves, that's tendonitis, that's overuse. That's doing a lot of activities in a short period of time that leads to just aggravation and inflammation to the muscles and the tendons. And again, bone stress reactions. And what I like to think about that is think about running. And after a while, your bones just start to hurt as you've been running just because of the pounding. And that's usually what leads to that kind of injury. So these are the common general injuries that we think of. But you can have these kind of injuries all over the body. And that's the thing, is that from your head down to your toes, there's lots of different injuries that people can get, all from doing the same types of activities. And again, there's a lot of specifics to this. Certain types of activities are going to lead to certain types of injuries. Again, we just talked about when I take care of football, I know that I'm going to be seeing a lot of knee and ankle injuries. I'm going to be seeing a lot of concussions. I know this. In volleyball, I'm going to see a lot of patellar tendonitis. I'm going to see a lot of shoulder problems. Same thing goes for swimmers. And so each type of activity has their own set of injuries that we have to look into. But again, it always goes back to what we just discussed further. So common weekend warrior injuries that we're going to talk about. And if anyone has any questions about these specifically as I go, please stop me, because I promise no one wants to hear me talk for this long consecutively. Shoulder and arm injuries, again, tennis or golfer's elbow, incredibly common. This is kind of like a midlife crisis of the musculoskeletal system. At some point, someone is going to get this. I currently am dealing with right golfer's elbow right now as we speak, and it is not fun. Rotator cuff disease. Everyone knows about the rotator cuff. It's incredibly common. Again, something that most people older than 50 are going to get at some point in their life. Back in neck injuries, neck pain, low back pain, incredibly common. And then leg and knee injuries, Achilles tendonitis, ankle sprains, knee pain, pain in the plantar fascia, and shin splints. And these are usually the most common ones. Yes, go ahead.
Why is rotator cuff disease, I've known a few people 50s and 60s.
Yeah.
They're not athletes.
Yeah. Give me 2 minutes and I will answer your question.
Okay.
I promise. Yes.
Okay.
So let's talk about that. So tennis and golfer's elbow. So this is mostly caused by overuse and repetitive types of activities. And so most people will get it towards either the outside or the inside part of their elbow. And it basically anything that involves grasping anything, lifting anything, twisting anything. So this could be in racket sports, this could be in gardening, this could be in carpentry, this could be typing. So pretty much everything that we do can cause this. And this is why most people will get this at some point. They usually will get tenderness, they'll get swelling, or they'll get reduced strength. And it's more of a nagging type of injury. It doesn't stop people from doing things necessarily, but the problem is anytime you try to make a fist or do anything, you feel that kind of pain, okay? Luckily this tends to be more of a self-limiting problem, but in some patients I've seen it can go for 6 to 12 months or even longer and requires more aggressive treatment. But in most people, this lasts several months and then kind of goes away and then goes away. And this is typically going to be in patients in their 40s or 50s, but incredibly common. Again, we talk about tennis or golf, but you don't have to be a tennis player or golfer to get this. And that's usually the first question is, but doc, I don't play tennis, I don't play golf. Why did I get this? But it's incredibly common. In terms of rotator cuff disease, whatever anyone thinks about rotator cuff disease, they usually think of two things. They think of, number one, I wasn't an athlete. I didn't throw, I wasn't a baseball player, and I didn't have a big injury. But 90% of rotator cuff disease is just from people that use their arms, which is pretty much everyone, and the wear and tear that goes with reaching or doing things overhead or whatever type of activity. It doesn't have to be from being super active. And so, again, based on the season, in the spring, I'll get a lot of people coming in with rotator cuff disease from spring cleaning. In the winter, it's going to be from shoveling the snow. And so all these types of normal activities that we think about over time can lead to just irritation and inflammation. And most rotator cuff disease, notice I use the word disease and not tear. Everyone's afraid of the tear. But the tear is basically towards the end of the spectrum. Those are the most severe. Tendonitis is just inflammation. It's usually associated with decreased range of motion or decreased strength. And if we can treat it at the tendonitis stage, we can prevent it from being a tear. And then we prevent things like surgery and those kinds of things. Again, a lot of time, we talk about kind of the severity. So you just have inflammation. You could have partial tears or full tears. And the analogy I use is in jeans. You wear jeans long enough, you get a little bit of fraying. That's just normal wear and tear. You don't really have to do anything for it. And then eventually, if it becomes a hole, that's usually what needs to be fixed. And that's wear and tear that's gone on for a very long time. And sometimes the tears can get so bad that it actually leads to arthritis and it needs to be something done more severe. Yes, question.
Is a lot of what you're talking about for the shoulder at least similar to the knee?
Yeah, so we will go through the knee too.
Yeah, but.
And that's the point about this, is that we're gonna talk about a lot of these conditions, but you're gonna see the same themes throughout. You're gonna think about, wear and tear, you're gonna think about decreased range of motion, you're gonna think about decreased strength, and the same types of symptoms, so absolutely. And that's the point, is that all these injuries are basically the same thing, just affecting a little bit of a different joint, so absolutely. Other questions? So neck pain, 2/3 of the population will have neck pain at some point in their lives. So incredibly common. The most common thing I hear is someone says, I woke up and I couldn't move my neck. My neck was just fixated and they couldn't move it. And there's lots of things that can cause neck pain, right? Just having bad posture, overuse, worn out joints, nerve compression, stress, right? All these things can lead to neck pain. And same thing, we talk about the neck. Decreased range of motion, decreased strength, just having a lot of tightness can lead to headaches, can lead to issues going down into your hand or fingers. A lot of these problems that are very similar to what we talked about before. And then again, going further down, you talk about low back pain. This is probably the most prevalent type of musculoskeletal problem that we see. It averages the most number of clinical visits and ER visits in the country. So this is incredibly common. If you look at the top right, about 80% of the population will have low back pain at some point in their lifetime. And it costs the medical community about $100 to $200 billion annually to treat low back pain. So incredibly common that at some point everyone is going to have to pretty much deal with. They say that about 1 in 4 patients is dealing with low back pain right now in the population. So it's definitely something we deal with. Again, different injuries or conditions and can range from very mild to very severe. But a majority of these can be prevented early on and not get to the point where it requires things like injections or surgeries or horrible things like that. Very similar. Achilles tendonitis, pain more towards the back of the foot, more towards the ankle. Again, caused by overuse, injury, tight muscles, not wearing the right shoes. And again, common now in runners, jumpers, and people who live in sports that involve sudden stops and starts. So basketball players, volleyball players, people that want to go back to those types of activities, marathon runners, those are the types of patients that will get Achilles tendonitis. Ankle sprain. So again, we talk about the ligament. Ankle sprain is when you roll your ankle. You hit a curb or you hit that wrong area and your foot kind of goes in and you stretch out all those ligaments there on the outside part. It can lead to a stretch, it could lead to a tear, and again, same kind of symptoms: pain, tenderness to touch, swelling, bruising, decreased motion, difficulties putting weight on it, difficulty weight bearing. Again, incredibly common. Go to the knee. So the most common portion of pain in the knee is usually to the front of the knee. Okay, so right around the kneecap, around the patellar tendon. This is also referred to as jumper's knee or runner's knee. And there's a lot of different factors that lead to this. So this is not just from one instance. And a lot of times patients will come, Doc, I don't know what I did. And I tell you, don't worry about it. It's probably from a lot of things that you did that just kind of came together. It's usually not from one specific injury. And so overuse, having tight muscles, having abnormal alignment, having cartilage wear and tear, being weak, all those things kind of go into play with this. And again, dull or sharp pain, burning pain, and then worse with activity. So it gets worse when you try to run, gets worse when you try to squat, when you try to do climbing stairs. And that's usually when people complain of pain, I ask them, do you have pain going upstairs? Do you have pain going downstairs? Do you have pain getting out of a chair? Those are the most common problems that we see with this. Plantar fasciitis, go ahead, yes, please.
How about pain on the inside of the knee and the joint and problems going downstairs, instability going downstairs?
Yeah, so a couple of those things. So, in terms of pain on the inside part, typically as the knee starts to wear itself out, it usually starts at the inside part of the knee. People start to kind of have that alignment where their knees start to kind of come out like this a little bit, because the inside of the knee is where most of the force through our knees go. And so we tend to wear out that portion of the knee first. And so that tends to be a little bit of early cartilage softening, a little bit of early osteoarthritis. And that's the most common. I'd say 80 to 90% of arthritis starts on the inside and then eventually goes to the outside. Remind me, I can't remember what the second question was.
pain going
Oh, right.
downstairs, instability.
Yeah,
And also the knee locking up.
Yeah.
Locking into a position and I can't straighten it out.
yeah. So when people talk about, when people talk about going up and down stairs, the most common thing people think about initially is that, well, going upstairs obviously is a lot harder. But actually, people that have knee problems, going down is infinitely harder. Because when you go downstairs, you're relying on that knee to basically support your whole body as you go down, and you have to bend that knee and go down. And so going downstairs is one of the last things I look at. And what happens is that when your knee hurts, your quad muscle starts to get very, very weak. If your quad muscle is weak, you need that muscle to keep your knee straight. If this muscle is weak, your knee gives out, you feel unstable. So a lot of this starts with having a lot of quad weakness. And if your quad isn't strong, you get that sensation of instability. You can't go up or downstairs. You can't get up out of a chair. You can't do a lot of the functional things that you want to be able to do. Now, as things progress and you start developing more kind of arthritic changes, you start getting more bone spurs, then you start to see some of those mechanical symptoms. Now, other things that can cause mechanical symptoms would be things like meniscus tears, loose bodies, cartilage injuries, and all those things can be looked at. But that's why, we always start off with doing an x-ray first, because kind of arthritis rules all. If you have arthritis, none of the other stuff matters. But if your knee looks good, then we can start to investigate some of those other things, meniscus injuries, cartilage injuries, ligament injuries, all those other types of things. But even in those cases, our treatment usually is get rid of inflammation and work on quad strengthening, because the quad is what rules the knee in terms of functionality. And so when someone has instability, they immediately go to, oh, maybe I have an ACL tear, or maybe I have a PCL tear, something along those lines. But most instability cases is due to having a really weak quad. And what I'll tell patients is that for every week you don't use your quad, if you're in a knee immobilizer or if you're at crutches, it takes a month to get back. So think about that. If you don't use your, if some people are in knee immobilizers for 4 weeks, that already is a 4-month recovery to get back to where they were. And so there's definitely kind of a increase in terms of needing help after having something like that. So did that answer your question?
More or less, but locking up would that be like bits and pieces in there?
Possibly that, or again, if you have arthritis underneath your kneecap and it's not gliding, it's rubbing, that could also be causing those issues. And so, the key thing for that is let's get an x-ray, see what are the mechanical symptoms coming from? Is it coming from just global loss of cartilage where it's rubbing? Or if that's not the case, are there, again, little loose bodies or things along those lines? Meniscus tears can cause the knee to lock up. And so that's something else to kind of look at. And that's where we make the decision. Do we look at an x-ray? Do we need to get an MRI? Those types of things as well as part of this. Other question? Yeah, go ahead.
Yes, I have the opposite problem. Going upstairs, it's
Mhm.
really bad.
Yeah.
It's very difficult, but I don't feel any pain in my knee. I feel a pain like in the back.
In your back, yeah. So in terms of that, we go back to kind of looking at low back pain. One of the most common problems of low back pain would be like sciatica, where some of the nerves coming out of the spine going down to give all the information to the leg muscles, that nerve is being pinched, whether it's from arthritis or herniated disc or just kind of narrowing. And then if that nerve gets pinched, now that the muscles that control strength aren't being told fire, and you can have weakness in your glute muscles, all the muscles you need to push yourself up. If those muscles are weak, then that's a problem. That's, again, we look comparing pain versus weakness. There's different things we do to treat pain. Weakness, we have to treat a different way. So we have to figure out, well, why is the muscle weak? Is it weak because it hurts, or is it weak because it's weak, either due to a tear or due to a nerve problem? And so in those cases, especially with, again, people will tell me, one of the common things we say is they'll say, Dr. Leonard, my hip hurts, and they'll point to here. Most pain going down the backside is more back. Hip is more in the groin. So this is hip pain here. Back pain is more down in here. Even though the hip joint is close, hip pain tends to go towards the front of the legs. Back pain tends to go towards the back. And so if you're having weakness and having pain going down this way, that's more suggestive of like a sciatica picture and a pinched nerve. And so the key there is to figure out how can we get that nerve to not be as irritated, so that then the muscles can get stronger and then help with going upstairs or doing whatever activities you want to be able to do. Yeah, please.
Does the sciatica always travel down, or can it just stay localized right in the knee, in the hip joint?
It can stay localized. It doesn't have to go all the way down. If it goes all the way down, that's usually suggestive of more severe compression. So it does not have to go all the way down for it to be a sciatica type of picture. But there's other things too, in terms of the back, that can cause pain to radiate just along the back side, whether it's just a little bit of spinal stenosis, pain coming from the herniated disc. So pain going all the way down is a nerve-related pain, but there's other things in the low back that will cause pain going down along the backside as well, but won't go all the way down to the foot or toes. Yes, please.
I was diagnosed with bursitis.
Mhm.
Is it different in this one than what we're talking about?
Yeah, so if we go here, bursitis in your hip,
Yeah.
yeah, I think it's probably on here. Yeah, if you look there, hip arthritis and then trochanteric bursitis. So
Okay.
the bursas are sac of fluid that usually sit between bone and skin.
Okay.
And they're basically used to kind of prevent friction. And so usually when you have things that are moving, you want something smooth to allow things to glide. But again, can you imagine if I take my hand to put something in and then continue to rub and rub and rub, eventually I'm going to develop heat and develop irritation. And that's what's happening to the bursa. So, the hip bursa is basically between the bones that you can feel here in the skin. You can imagine if you keep walking, eventually the analogy I give is it's like going from a sack of fluid to a bag of potato chips. That's what the bursa feels like now, with crunch, crunch, crunch. And you have bursas in your shoulder, you have bursas in your elbow, you have bursas in your knee. And when those get irritated, they start to make noises. They can, or they don't have to be painful, but they can be painful. And in those cases, what we're trying to do, number one, is calm down the bursa, right, with ice, anti-inflammatories, or injections. And then we're trying to prevent the rub. And usually the rub is when you have a muscle that's super tight and just rubbing really against it. If I can make it more loose, it'll glide over the bursa as opposed to rubbing really hard. That will decrease the friction and allow things to feel better. So that's traditionally what we do for something like that.
Okay, thank you.
Go here. I want to go here. So I think the point of this is that there's a lot of kind of similarities between all these different types of problems. A lot of this is either overuse or repetitive activities. Notice that none here did I talk about any sort of trauma, except maybe for ankle sprains, or being like this high level athlete, because that's not really that common. This is overuse and repetitive types of activities. Typical complaints, people will have pain, they'll have swelling, they'll have stiffness, they'll have weakness. And when we do our exam, we'll find that their range of motion is decreased, their strength is decreased, and that their alignment and posture is poor. And so those are the things, what I tell my residents when I'm teaching them is that, you should know based on the age of the patient and what their complaint is, what their problem is when they walk in the door. And so when we're doing a physical exam, we're doing it for, well, how can we fix their problem? Are they stiff where they need help? Are they weak where they need help? Or are they really inflamed? And that will help to determine how we treat this. It also is helpful for helping to confirm the diagnosis, but again, most of this should already be known going in. So again, I kind of tend to divide my treatment goals into three kinds. Number one, we want to decrease pain and swelling, no matter where that is. Number two, we want to restore range of motion and strength. And number three, we want to optimize functional movements. And it's really important that we do this in the right order. And so nothing drives me crazy more than someone who's been seen by somewhere else, and they come in and we'll just say their shoulder, just because I see this most commonly, their shoulder is really painful. And they go and they talk to whoever and their shoulder's painful, or, a lot of times you can actually just go right to physical therapy. You don't even need to see a doctor. And I think for certain circumstances, that's really good. If you have a painful shoulder, do we really want you going and doing exercises? I mean, that just never made sense to me. You're just going to aggravate the problem. And so, but that's often what happens. And then they'll come to see me and they'll be like, that therapy sucked. It made me feel worse. I hate it. I'm never going to go back. Dr. Leonard, don't ever send me back there again. And the problem wasn't the therapy, it was the problem in the order in which treatment was given. And so you got to get rid of pain first, then you work on your range of motion, then you work on your strength. Another analogy I'll give is, if I pull my biceps muscle, the last thing I'm going to tell a patient is, well, you know what, just do 25-pound curls. I'm sure you'll be fine. I mean, it makes no sense, right? Why would you start working on strength if they're hurting? But I see this all the time. You have to do things in the right order. So the first thing is getting rid of pain and swelling. And a lot of this stuff makes a lot of sense. And most patients are actually doing a lot of these things. And that's why, people will say, well, I've been having the symptoms for 2 or 3 months. That's actually pretty normal because most things will go away in that time frame, right? And if not, people are smart enough, or you could Google things, or you ask your primer and they say, well, you know what? Just do some anti-inflammatories, do some ice and do some rest and you'll do okay. And for a lot of these conditions, I think that's fine. In sports medicine, we don't believe in true rest. I like to refer to it as active rest. And what I mean by that is that if you hurt your left knee, that doesn't mean you should lay in bed all day. That means, okay, do some upper body work, do some core work on your other leg, let what's hurting rest, but work out everything else. No longer do we ever recommend bed rest for low back pain. People have low back pain, they lay in bed, and what happens? You get tight, and it gets worse, right? You got to get it moving. And so, they used to be the thing is go lay in bed for 2 weeks, but then they never got better. And so we got to get things, moving. Anti-inflammatories for people that can take them are wonderful. Sometimes there's a fear that we're masking the pain, but we're not. A lot of this, as we said, is inflammation due to overuse. So this is not pain medicine per se. We're treating the problem, which is helping with the pain. And then steroid injections is the last thing I can't remember now. I know that there's a lot of kind of negative vibes and negative press when it comes to cortisone injections. And I don't necessarily blame people for that. I think sometimes, people think about steroid injections as being kind of the magic pill that's going to make everything go away. But I think that, again, in the setting of inflammation, I think doing a cortisone injection is actually a really, really good thing. It puts the medicine right where the problem is. Even with anti-inflammatories like Motrin and ibuprofen, it's hard on the stomach. It's hard on the kidneys. It's hard with people who take blood pressure medicines. It's hard for people that are on anticoagulants. And so there's a lot of issues with these NSAIDs as well. Whereas if they can't do it, I think a steroid injection is a really good idea. Generally, unless you have arthritis, it should be a one and done kind of phenomenon. Okay. Cortisone gets rid of inflammation, which is a wonderful thing, but that also means that it's stopping the body from healing. And you can do that temporarily, but if you keep doing it and keep stopping the body from healing, it's going to actually lead to more damage. Now, if someone has really bad arthritis and their next step is a knee replacement, you can get cortisone for as long as you want because it's not going to matter in the end. But for a lot of these soft tissue problems, I'm very careful about not doing more than one because I don't want to create any more problems. But I think doing a singular cortisone injection done into the right space is actually a good idea. But again, we start with rest and activity modification, we use ice, we do NSAIDs, and then steroids is always going to be the last resort for that. Questions on that? Pain, swelling, those kinds of things?
How often can you get a cortisone shot?
So I guess a lot of it just depends on the general rule of thumb is 2 a year, every 6 months to the same joints. That's generally the rule of thumb. Now, that doesn't mean that doing 2 shots every year for 10 years is a good thing. That's a bad thing because you're just, but there's no hard, fast rule. But if I give someone an injection and in 6 weeks they go, yeah, that injection lasted me 4 weeks and now the pain is back, doing another injection doesn't make sense because we haven't helped them. That's not enough of a gain. And then that's where I have to look at, well, why did this pain come back so long? What else can we do to help with that? So I think, every 6 months plus, that tells me that it's working and it's something that I definitely would kind of look at doing. So, yeah.
What are your thoughts after X-ray or whatever, ruling out injury, like an actual injury, if that's ruled out? What about alternative treatments like acupuncture or chiropractic?
Yeah.
Or
Yeah.
things like that?
So I think that I think in terms of the acupuncture, the chiropractor, I think the chiropractor is wonderful for dealing with these kind of acute injuries. If you have a muscle strain or a ligament sprain and you have acute pain from an injury, that's what a chiropractor is trained and educated to treat. And they will do a good job. They will relax muscles. They will get things moving like they should. They are definitely helpful for an injury of the muscles or the ligaments or the tendons. What they cannot do is they cannot change a long-term problem, okay? They are not, so my rule of thumb is that if they recommend more than 5 sessions, turn around and go the other way because they're not capable of taking care of long-term problems. All they're doing is giving you short-term relief but it's gonna come back. Okay, so I think in terms of short-term relief, wonderful, go do it. I'll send my athletes that have some of these muscle injuries and such, but they are not changing anything to your alignment. They are not correcting any positional or postural things. The only thing they're doing is releasing some muscle tension to help with pain. I think acupuncture, again, another wonderful modality. I think all these modalities are helpful in helping get rid of pain so that then we can correct the problems on a bigger scale. So I don't necessarily have any problems with that. A lot of chiropractors are now partnering with physical therapy. So the chiropractor gets people feeling good, and then the therapy will help with the long-term course. And I think that those are fine to do. Other questions about? Other things that you might have seen in addition to steroid injections, people are using gel injections now, people are using stem cells, people are using PRP. None of these things have a lot of strong science behind them, okay? You want to ask the question over why people are doing injections in the mall is because they're asking for cash. Why are they asking for cash? Because Medicare says, we don't know that this works. We're not going to pay for this, and no insurance will pay for it because there's no data to support it. So that's the reason why, is that insurances will start to pay for things when there's good science to back it up. And I'm not saying that it doesn't work. What I'm saying is we don't know if it does work. And so that's why they're not necessarily paying. And so, be careful. Just because something is super expensive doesn't actually mean that it actually works. And so, some good early studies with PRP for things like tennis elbow, patellar tendonitis, different types of tendinopathies. We are using gel injections for arthritis that have shown to be good about 60 to 70% of the time. The question about stem cells is that, when you inject a stem cell into a joint, how does it know what to do? Doesn't, you can't tell the stem cell, form cartilage right here, right now. We don't know that enough to do that yet. We just don't. So it's still, it's still experimental. We're still investigating it. Could it potentially lead to something? Absolutely. Can I tell you for sure that it doesn't work? No. Can I tell you for sure that it does work? No, I can't. So that's the reason why. Next step. We want to restore the range of motion and strength. Most people that get these injuries have some amount of stiffness or some amount of weakness. Whenever I see anyone who has any sort of shoulder problem, almost all of them have some sort of stiffness somewhere, and they probably didn't even realize they had it. And so this can be done through either home exercises or formal therapy. You do not have to go to formal therapy if you do the home exercises. Just taking the sheet of exercises and putting it in your pocket has not been shown to be effective. You actually have to do them. And so some people, want the formal therapy to kind of learn. Other people like, no, I'm going to do this on my own. Either one is effective. And, we give a home exercise program where you take it with your phone and it goes and it sends you right to videos that show you how to do them. So there's enough technology now as to where you could actually be shown how to do these exercises. And again, the goal is we want to get rid of the joint stiffness. We want to improve strength. And then once we have the motion and strength back, then the goal is, okay, what is your functional goal? What are you trying to get back to? And when you look at all these problems and you look at the pain and doing these exercises, generally they tend to be about 85 to 90% effective. So only in 10 to 15% are we even talking about MRIs, or are we talking about surgeries? I know I'm an orthopedic surgeon, but I would say only about 10 to 15% of my patients ever actually get to surgery. If I operated on everyone, I promise you I would not cover any teams, because no one would want to take care of me because I'd be operating on other athletes. And so the goal here is not to have surgery. The goal is to fail everything else and then need surgery if you needed to, but that's incredibly rare. So when do you see the doctor? So I think if you have a traumatic injury, if you have a fall, if something happens where you went from no pain to all of a sudden, boom, I have a ton of pain from an injury, I think that's when you should be seen. That's when we want to make sure you didn't break a bone, you didn't dislocate a joint, you didn't tear something. That's, I think, kind of the key. If you've been having pain for the last 3 to 4 weeks, it just does not seem to be getting better or is getting worse, I think that's a good idea. And then if you're not able to physically do your normal activities, you can't wash your hair, can't tuck in a shirt. The biggest, most common complaint I see is Can't sleep. That's usually what brings people in, because if you can't sleep, you're miserable at night and you're miserable during the day. And so those are the things that I would say are key things to look at. So reasons people don't go see the doctor. They think the pain will go away on its own. And again, we talked about that. I think that's cool. I think, 6 weeks, 8 weeks, 10 weeks, even up to 3 months, if you're having pain, more than likely, it usually goes away. You do some ice, you do some anti-inflammatories, most pain go away. But if you get to 6 weeks, 12 weeks, 3 months, and it's still going, it's probably not going to go away at that point. They don't want surgery. And again, we mentioned that only about 10 or 15% of patients that actually go see surgeons actually end up having surgery. And what I tell patients is that no one ever needs a shoulder or elbow surgery ever. So I make the recommendation, but they're the ones that are telling me, Dr. Leonard, I'm ready to have surgery because none of this other stuff is working and I can't do A, B, or C. They don't want to be taken down. So that's the big thing. They can't miss work. They want to continue to do sports. They have a lot of work to do at home. They have to take care of their family. And I think all those are reasonable excuses that are involved in the decision-making process. I have to treat the patient first and not the shoulder. I'm not going to say, well, don't worry about your mom that's 90. She's going to be fine. Let's have the surgery now and do this. I mean, that doesn't make any sense. Same thing goes with my athletes. If I have someone who, injures their shoulder the first few weeks of the season, I'm actually usually going to try to get them through the season. And then if we need to do something aggressive, I'll do it at the end of the year. So it's all about knowing when to be aggressive and when not to be. And, some patients have to work. They're taking care of their family. I'm not going to pull them out of work to have surgery. That makes no sense. And so those are things that are involved in the decision-making process. We have to look at the whole person, not necessarily just their problem. So in terms of what happens at the evaluation, we talk about what bothers them. We go through their medical history, and then, I would always be leery of a doctor that does not touch you, that does not do a physical exam. Okay. Here's your problem, go get an MRI is not appropriate. It never is appropriate. And we'll talk about the MRIs in a second, but if you have someone that's not doing a physical examination, they probably shouldn't be seeing that person for that problem, because there's a lot of good information you can get from the physical examination. Again, not necessarily what the problem is, but how to treat it. What do we need to do to treat this? And so if they're not doing that, then they're not helping with the process. And then I always end up getting an x-ray of the joint, because like we said before, arthritis is king. And the analogy I give is that some people will get a frozen shoulder, okay, where for whatever reason, their shoulder just gets tight, okay? And the analogy I give is if your shirt shrinks, you can't move it because the tissues around it become really, really tight. In those patients, the treatment plan is aggressive therapy, stretch it out, get all the motion back, and about 95% of those people do fantastic and get better and don't need surgery. You can have the same person come in with the same exact complaints who has really bad arthritis. And if you miss that, you send them to therapy will absolutely torture them. You will go, and then they will have so much pain that they will not be happy. Okay. And so that's why I think, again, getting the x-ray is super important. And that's also another reason why one of my pet peeves is when a doctor will tell a patient, well, you have arthritis, without getting an x-ray. Unless that person is Superman and has x-ray vision, you can't assume that pain is just from arthritis, because as we talked about, it could be tendonitis, could be bursitis, could be all these different types of things. Yes.
Arthritis shows on an x-ray?
100%.
Okay.
That's why you get it.
Okay.
That's absolutely why you get it, is to rule that out. And so that's why it's so important to get it, is because, again, the fracture is one thing, but it's to rule out the arthritis that changes how we treat this. So it's super important to get it. It's super important that the diagnosis of arthritis come from an x-ray. That's the only way to make the diagnosis. All right, so MRI, we're going to talk about the MRI. The indication to get an MRI is surgical planning. Okay, I know I'm going to operate on this person. We've come to the consensus. I'm getting an MRI to go over what we're going to do in surgery. If people are getting MRIs because they don't know what else to do, that's a problem. And the reason why is that when you get an MRI, the images get sent to a radiologist who's usually kind of at home in his basement, who knows nothing about you. They look at the picture, and then they come up with a list that's this long of all the things that you have wrong with your shoulder. That gets sent to your primary, who then gives it to the nurse in the office, who then calls you and then reads the long list of everything that's wrong with you. And then you hear that and you're like, oh my God, my arm is gonna fall off and I don't want surgery. I'm not gonna see the surgeon because I don't want surgery. And so they never come in. And most of the stuff that's on there is a bunch of nonsense. And so, usually when people come in, I'm having to talk them down off the ledge about, no, you don't need surgery. Yes, I know your list is this long, but if I get an MRI of someone who's in their 60s, I can tell you right now, they're gonna have a labral tear, they're gonna have some chondromalacia, they're gonna have some rotator cuff inflammation, they're gonna have some bursitis, and they're gonna have a type 2 acromion, every one of them. And those are people that are perfectly healthy, they have no problems. And so that's where, again, it's got to fit in the picture. You got to know the person about this. But what are we looking for? We're looking for tendon tears or ligament tears. We're looking for disc herniations. We're looking for compressions of the nerve, significant weakness or failure of conservative treatment. This is why to get an MRI. This should be the last step, not the first step. This should never go in front of a physical exam. It should never go in front of an X-ray. It should never go in front of treatment, frankly. And so we do too many MRIs as a profession. That's on me and that's on us. And so the residents get annoyed because I get on my soapbox about MRIs, is because I think that it's a wonderful tool. Done appropriately, done inappropriately, it can lead to a lot of stress. I know patients that were up all night worrying about the visit for the follow-up of the MRI because they were afraid they were going to need surgery. And so I think this is important. So how do we prevent these? Yes, please.
Can you explain to me? I have a kind of vague idea. What is the difference between a tendon and a ligament?
Yeah. So the ligaments are the structures that connect bone to bone. Okay. So they keep bones that are in a joint together. So it prevents your knee from giving out. It keeps your ankle together. It keeps your wrist together. It basically keeps your bones together. Okay. The tendon is the part of the muscle that connects to the bone. So the tendon is what does all the moving. Okay. So all of your muscles have tendons. And so the tendon is the part of the muscle that connects to the bone that allows for movement. So when you have a joint that's unstable, that's giving out, that's usually a ligament problem. If you have weakness, that's usually a tear in the tendon. So that's the differential between that. All right, so what do we do to prevent these? So I think number one is building up activity level. Everyone is so excited and wants to start getting back into things. And, again, as a different fad comes up, people go into these things, but it's important that we start to move things gradually. When I tell an athlete that they're going back to sport, I always tell them, start with something that you can repeat the next day. Start very low and then build up. What I don't want is someone going really hard, then being sore for 3 days, then going really hard and then being sore for 3 days, because they're never going to make any progress, versus starting off really slow and simple and then building off that. That's the way of doing anything as you start to get into a workout or a program or any of those types of things, whether it's you're going to add more minutes, you're going to add more reps, you're going to add more weight. Start off really low and slowly increase your activities. Simple stuff, warming up, stretching, just doing 10 or 15 minutes of just kind of moderately paced activities is good. Doing stretches to get things loose, I think is really important. A lot of these injuries, again, cause from muscles being tight. And so loosening those up is actually really, really important. Proper technique and appropriate equipment. I talk about going to formal physical therapy to have a therapist go over what you should be working on. The same thing occurs with workouts, and whether that's doing it in a group training session or getting an instructor or a personal trainer, I think all those things are helpful. And then making sure you have appropriate equipment, footwear. Shoes tend to wear out after 200 to 300 miles. And so keeping shoes for longer than that increases the chances of stress. Making sure that you're using the equipment appropriately, making sure that you're safe. Hydration, we kind of get back to this, but everyone should be taking about half their weight in water on a daily basis. Virtually no one does that. So, you look at how healthy muscles are when they're well hydrated, they move better. So just being hydrated, I think, is super important for this. And generally, about a quarter of that should be first thing in the morning when everyone is super dehydrated. They haven't taken anything to drink. They've been sleeping. It's dry. So, if you're 100 pounds, you should be doing 50 ounces of water a day, and about 15 of that should be first thing in the morning. And that's a general rule for hydration that again, can prevent a lot of these things. And then the most important one, or actually, we're gonna talk about this. I like the concept of weight loss for this. And so if you look at these activities, this is kind of what the knee feels when you're doing things, okay? So if a patient were to lose 10 pounds, okay, they would feel 5 pounds less stress with walking or biking. They would feel 33 less pounds with going upstairs. They would feel 50 less pounds going downstairs. They would feel 70 less pounds jogging, and they would feel 200 less pounds doing a deep squat. So just from losing 10 pounds. So think about the amount of stress this takes off of your knee. So there is an exponential improvements based on any sort of weight loss. And so I think that that's something else that we kind of look at from only a small change can actually make a big difference, especially when people are trying to be active and go back to doing things. The final thing is don't be a weekend warrior. How do you prevent weekend warrior injuries? Don't be the weekend warrior. So doing things on a daily basis, as opposed to, again, trying to concentrate it in a day or two, I think is helpful towards, again, just getting back to just being healthy and preventing these types of injuries that we see. Some of it is less realistic than others, but I think that's really kind of the key component of this. And that's my talk. Questions? Yes.
How do you then interpret like osteoporosis?
Yeah. Yeah.
You know, how does that affect the pain and the motion issues? And
So I think, you know, true osteoporosis does not hurt, right? Osteoporosis doesn't hurt. What osteoporosis does is increases the risk of a cataclysmic fracture, right? Back, shoulder, hip. And the key to this is actually flipped, is that we want this. We want the daily exercises because the increased stress on the bone stimulates the bone to get stronger.
Right.
And so that's what we're trying to do. But if someone is being more active and they're weak or they're stiff or they lack balance and they fall and they have osteoporosis, that's a problem. And so, and it's not, in terms of osteoporosis, this is more weight bearing and resistance. You know, it doesn't have to be running or aerobic activity. Aerobic activity doesn't really do much for osteoporosis, but it's doing band work and weights. And again, we're not trying to figure out what your max is, but doing exercises where we're able to do 10 to 20 to 30 reps, because that muscle contraction kind of presses on the bone, stimulates it to get stronger so that we can prevent any type of fracture. And because it's the fracture that leads to the pain, not necessarily the osteoporosis by itself. Other questions? Yes.
I have a few.
Yeah, please.
Okay, one was when you mentioned chronic pain, 3 to 4 weeks to see a doctor.
Yeah.
What about chronic recurring episodes where, you know, over years, it'll be fine and then, like, I'm speaking for him, like then his knee locks up or
Yeah.
whatever, and he has to rearrange it, and work
Yeah.
on it, sore for a while, and it goes away for indefinite time, and then it's chronic, repeated chronic.
Yeah, I think if it's repeated chronic, I definitely think that's something, because there's something that's repeatable here that continues to happen. And those types of things is basically either some loose body that, you know, again, the analogy is like having a pebble in your shoe. Sometimes it's off to the side, you walk, don't even know anything is there, right? But then if it rolls underneath your foot, you walk on it, you feel it. It's still always there unless that physically gets removed. And so in cases where people are having repeatable mechanical symptoms, that's less likely arthritis, because arthritis is always there. That should be constant. If it's recurrent, that tells me that's something that's moving around. That makes me think meniscus tear. It makes me think loose body. Like a loose body. So a piece of cartilage that broke off from where it was on the knee and is now floating around the knee, causing all kinds of things.
And is that's a surgery, right?
So typically, if someone has a loose body, right, you got to get rid of the pebble. And so that usually is a camera surgery. 2 poke holes go inside the camera, find the loose body, pull it out, and then that's it.
Relatively minor.
That's very minor. Correct. Yes.
And then you can see on an X-ray.
Sometimes not. Sometimes you have to get an MRI to see those, because if it's cartilage, that doesn't necessarily ossify like bone, you may not see it. So you get the X-ray. If you see it, then great. If not, then you would probably, that would be the case to go to an MRI. Why? Because now I'm thinking about a surgery for you. I'm thinking about you're having these chronic mechanical symptoms that come and go. Sure sounds like something's floating around in there. The X-ray is not showing me what I need. Now let's get the MRI because I don't know what's going on. I'm looking for two specific things here. I'm looking for a meniscus tear. I'm looking for a loose body.
Even though you're a specialist in shoulder and other stuff, you're still do knee.
I do shoulder, elbow, and knee. I don't do knee replacements anymore, but I try to, but again, with my sports athletes, I still do ACLs and meniscus. And so I do camera stuff. I do arthroscopic knee.
Yeah, but I mean, is
Yeah.
the person better to go to a different person for specifically knee trouble?
I think, part of that again is we become so super specialized. I'm worried that we're going to eventually have the right knee surgeon that only does right knees.
So you're fine with that,
So yeah, I think that's fine.
Okay.
There's a lot of overlap with the knee.
So my other question was for your everyday young senior
Yeah,
that just wants to be in good overall condition
Yes.
and preventative
Yeah.
care.
yeah,
I have
That's all.
found, I used to be extremely fit long ago,
yeah.
and it was a different, everything was different then. I can't find just like not even a trainer, just a way to get a general plan that's gonna be efficient for the needs of my age and a general overall routine.
Yeah,
Whatever weights, walking, whatever.
Yeah.
That's, I'm looking at efficiency and doing it right,
sure.
without going to some high-end personal trainer that's some guy just out of college and charge you a fortune. It
Agreed.
doesn't necessarily help.
Yeah. So I think,
Give ideas.
so I think in those cases, typically we talk about wanting to do something every day, right? And so generally the rule of thumb, what I'll tell people is that you want at least 4 days of doing cardio. And that could be, walking, that could be biking, that could be, that can be just, again, I see people doing 20 or 30-minute power walks every day. That's fantastic, I think that's okay. And then 3 days of doing kind of resistance training, band work, those types of things, light weights. Those would be the things that I would recommend.
So about where to go or who to get or how to work that in terms of, like for me, my needs for weights, like how much weights and what type of weights and how many repetitions. I mean, there's so much to that,
I know.
to just go play around.
I think,
to make things worse.
a lot of it is, a lot of, a lot of villages now have like group classes for seniors where they're doing things where you're kind of being told what to do. So instead of going like to the high-end specific like gyms or things along those lines, most communities or a lot of that, health providers will actually do kind of group training, group sessions, those types of things. I'm sure even Advocate has something like that too.
Yeah.
I'm almost
and
positive.
Especially like, I used to do the sensory bike rides and all that stuff.
Yeah,
And I did all the things to prevent knee injuries and things like that. So
yeah,
now I'm not doing any of that anymore, but I'm still remembering there's certain things to do to even a little bit of bike riding that'll help you.
bike riding is one of the best things you could do because it's low impact on your knees.
Right.
It works on motion, it works on quad strength. So
at
biking
this-
is a wonderful
So
thing.
at this point, with just a little bit of bike riding, I probably don't need to worry about strengthening the right muscles.
If
and
you
all that,
did
right?
biking, I think you'd be fine from a lower body standpoint. Then I would just make sure that you're doing something with your core, and then you're doing something with your upper body. And I think if you did those things, I think you'd be fine. Yes.
I'm a young senior.
I
I'd
like it.
And I found silver sneakers as part of my program, my insurance program.
Okay,
It's been very helpful. So check if you do have like Medicare and a supplement insurance plan, check your insurance plan.
a lot of the insurances now are really pushing for preventative care
Yes,
because by preventing injury, the insurances save a lot of money.
right.
And so a lot of them, and I do know, there's a lot of insurance companies that will do things for weight loss, that will do things for cardio, will do weight training. You can basically get a lot of those things for free
Yep.
via the insurance. So that actually is a great,
They do, band work.
Yeah.
They do Pilates for beginners.
and it's gotta be something fun that you wanna do too. That's why there's so many different things, like, some people, don't like the training of it, like I like doing weight training at the gym. My wife absolutely hates it. She's like, I don't wanna write down how much I lifted or
I do
things like
mine
that,
online
so,
too, by the way. Use your
Yeah.
phone.
yeah.
Yeah.
So, great suggestions. What else? Other questions?
Quick question, talk about exercise, what about concentrating, like keeping range of motion,
Mm-hmm.
your shoulders, your knees, your ankles,
Okay.
Yeah. I think, again, what I tell people is that, you should be doing, my mentor once told me that as we get older, we have to do exercises that normal things don't hurt, right? We naturally get stiff and we get weak. And so people should be doing mobility stuff every day for 15, 20 minutes. And they should be doing some sort of aerobic, again, 3 or 4 times a week, and they should be doing strengthening a couple times a week as well. I think that if you start to notice that certain positions start to hurt, that usually tells people that they're stiff and they have to work on mobility. But it's even more than that. It's low back mobility, it's pelvic mobility. The problem is that, it's more about kind of functional movements now, where we're going away from, okay, let's stretch our hamstring like that. I mean, when do we ever really do this as in a functional movement? So a lot of times we can incorporate functional movements into a program to kind of help with that as well. So, again, if people get a joint that hurts, that's usually what I'll have them do more specific stretches to open them up that way. But it's more about kind of functional movements at this point. What else? Other questions? Yeah, go ahead.
If everybody else, I think it's the last one.
It's okay.
When you talk a lot about the joints and stiffness and mobility and
Yeah.
that joint comes up a lot. What do you think about targeted supplements, products such as like a relief factor and so on for people that definitely have, joint stiffness and pain? Do you have comments on that?
I just don't know if any of that stuff really does anything. That's my thing with all of these things. If you go to, any sort of supplements, I tell people is that there's a 50% chance that it may work. So for all those things, what I usually counsel people on is, again, it's one of those things where, can I tell you that it doesn't work? Can't. Is there a lot of good science to support it? Not really. But most of them tend to be cheap and they don't interact with any medicine. So they're generally all pretty safe to take.
So I thought you might have had feedback maybe from some of your patients that may have been using that or trying.
So I like to do, I'll do like any sort of glucosamine chondroitin type of supplement for it. And I would say about half of them get better and half of them don't. And that's unfortunately typically what ends up happening. And people ask, what's the dose, fluid, pills? There's not much to that, unfortunately, because again, what you're trying to do is trying to keep the cartilage in the joint healthy, but it doesn't necessarily know that that's what it's supposed to be doing when you take it in.
Wrists.
Same kind of process, but the problem with wrists is now we're starting to get into much more finer movements, and smaller problems have much higher impacts on things, because of that. That's why the hand and the wrists are so difficult, is because you have more nerves in your hands and fingers, which makes sense for tactile. That all tactile function, but that also means that things hurt a lot more. Small breaks, small cracks, stiffness is a really, really big problem. And so when it comes to the wrist, most wrist injuries though typically tend to be post-traumatic. There was an injury that occurred that led to it. A lot of the same concepts we'll do, injections and ice and braces to calm down the inflammation, and then we'll work on motion. But, the wrist, as well as the elbow and the fingers, the biggest issue is stiffness. They get stiff really fast. And sometimes when they get stiff, we never get all the motion back like we would in other joints. And so it's really important for that as well. And, again, just something as simple as making a fist. In order for you to make a fist, your wrist has to be able to cock up, right? If you try to make a fist like there, you're not going to be as strong as you pull it up into this direction. So there's a lot of things biomechanically that are impacted by the wrist. So.
All right, thank you very much. Oh, another
one
question,
last
go ahead.
This will be it.
That's okay.
Young people playing baseball,
Young people, yes, the young people.
throwing a curveball.
Yeah,
Does that, you always hear the myth, they threw the curveball too early and they ruined their arm. Is that true?
no,
Okay.
that's been proven more times than not to be an inaccurate statement. Now, a couple things about that. Number one is that if you have someone that's really young that throws a really good curveball, what else do? they throw a lot, right? They're playing in every game, they're throwing in every game. If they're good, they're gonna throw. So it's not the act of throwing the curveball, it's just the act of throwing and the more throwing. And so most of the work we're doing with young throwers is limiting pitch counts, limiting innings thrown, trying to get them to stop throwing all year. That's the other thing is that now with domes, you can throw 12 months out of the year. There's always a showcase going on. And so most of this is just more overuse than actually true snapping, interestingly enough, I think it's the people that throw harder put more stress on their arm at an earlier age, and that's usually what actually ends up leading to the problem. So, but the curveball in of itself, by itself, no, out, yeah. All right, thank you, everybody.
If you would just, complete the notes